Hello. Hello.
Hello. I hope you guys enjoy today's session. We're going to get started in about 10 minutes.
Okay.
Thanks.
Thank you.
Hi, Jane. I cannot hear you.
Oh, I was on mute. There we go.
You know, can
Yeah.
You're gonna laugh. I actually practice how to
Good.
present with teams
Good.
to avoid any confusions. So why don't can I just really quick share, see if it's
sure.
gonna
You can
work
do
on my
whatever you want. Play around and help yourself.
Hi, Julie. Jen, this is Julie. She's a new member of our team.
Hi, Julie. Nice to meet you. You're muted, just so you know.
And that's, yeah. Okay. Are you able to see my slides?
Yep, that's perfect.
Okay, now I want to just kind of check a video.
Okay.
And I want to make sure that the sound coming.
Okay.
Give me 1 second.
Sure.
This one, that one. Can you hear?
Yes, I can. Yep, it's working
Awesome.
perfectly. Nice work.
Awesome. Okay, stop presenting.
Your practicing worked.
I did. I actually did.
Then
the last one I want to see, it's I want you to let me know if you can see my PowerPoint. It's gray and
gray and white. Yep.
Okay, I'm all set then. Ready.
Perfect. All right, we'll get started in about 6 minutes. Terrific.
Sounds good.
I'm going to mute and turn my camera off in the meantime. So
sure, that's fine. I cannot hear you. I cannot hear you. Did you mute yourself? Huh, I don't know. Anyway, that's okay. I want to kind of see. Okay, perfect.
welcome everyone. We're just going to wait a few more minutes for everybody to log on and then we'll get started. Hey everyone, we're just waiting for a couple more minutes for everybody to log on and then we'll get going. Welcome everybody. Is Naftali joining today, Martha?
He's supposed to.
Okay. Yep, I think we'll just wait about one more minute because we still have several people that are not on. So we'll just wait one more minute and let, people are usually jumping between meetings. So we'll just wait a minute. Okay, let's get going, everybody. Welcome to the fourth installment of the Collaborative Family Health Association's training modules with WCHQ and the Medical College of Wisconsin. We are so happy that you're all here participating. I want to make one quick announcement, then I'm going to turn it over to Martha and Naftali. I asked to join your one-on-one TNA sessions, not to be a spy, but really because I want to take great notes and use that information to share with our funders, not naming your organizations, but talking more globally about the great work that you guys are doing and the things that you're working on. If you're not comfortable with me joining a session, I totally understand. And if you would just do me a favor then and take some notes yourself and send them to me, that would be great. But when you sign up, if you let Naftali and Martha know that you're not comfortable with that, that's perfectly fine. But again, take really good notes for me so we can use those to send to the to AHW so we can continue to get funding to help you guys get technical assistance. So that is my only announcement, and I will kick it over to Martha and Naftali. Thanks, everybody.
Thank you, Jen. I have actually been failing to introduce ourselves really quick in each session just because I assume everybody that joins you have joined us in the past. But for those who is the first time joining us, my name is Marta Saucedo. I'm the project manager for technical assistant and strategic development at CFHA. I'm here with our CEO, Naftali Serrano, and our new colleague who just joined us to the team this week, actually, Julie Gaylor, who will be also supporting us in the TA department. I'm not going to spend too much time on introductions, just want to put out there our names. And to feel free, like Jen mentioned, contact us in order to get those one-on-ones with us to support your site. We have been getting some of you already reaching out to us, but we need more. So reach out and in order to help you. Let me share my screen here, and I'm going to start giving the presentation, and Naftali is going to help me actually coordinate the chat and get some information there reading. So feel free to, write questions in the chat and be mindful of also reading the important information that he's going to share over there. So waiting for my presentation to appear.
We can see it, Martha.
You can see the presentation already?
Yeah.
Oh, I didn't.
That's it.
I did not.
I have not had that happen.
Okay, great. Well, today it's our fourth session, and we're going to talk about staff development part 2, which is basically the care team. So last month we talked about how to get a good BHC in place on a site, how to be thinking and having our mindset. Now let's talk about the people that surround the BHC person in the clinic. And we're going to start with, this is a common question when there's only one BAC in the clinic or they just starting the program. It's very hard for people in the clinic to have buy-in in the integrated model. So we're going to go through the things that usually are difficult, to get that buy-in and how to improve those things. Usually so this is actually like a resume of what we're going to be talking in detail in our next slides, but we're going to mention the reflection of the BHC. So we need to make sure that whatever the BHC is doing is exactly what the providers are doing as well. And that match everything, like how they do their schedules, if they're included in meetings or anything on the clinic, like in the leadership group or not. So everything that mirrors that. We're gonna talk about how to check their schedules, scrabble their schedules, and be able to invite the providers that we can actually help them in the patients they're gonna see that day. It's important to also make those connections with the medical assistants or the nurses as to they can be your allies and help you through that flow and the process. We're going to ensure that providers understand how to introduce you. A lot of the times we hear that providers will say, well, I was actually told the patient that you were here and you can help, but they denied your service. So we will gonna look into why that sometimes happen, how to help providers when they're running behind and actually facilitate the flow, and mainly build the trust that we are a valuable part of the team and that we're there not to complicate things, but completely the opposite, and remove all misconceptions as to what we're doing in the clinic. Okay, so in order to help the providers overcome and get that buy-in, it's important that we are effective on how we're going to be reporting to them or give them input in regards to a patient. So we don't want to get on their way. We don't want to give them a long explanation as to why we think it's important to see a patient or not. It's going to be quick and to the point. That includes also with the way we're going to be communicating, not just verbally, but written with our notes. And that's actually something that we're going to be talking about next month in our 5th session, how to really create effective notes that they're concise, but they really give the important information that providers need, but also the other teammates around your clinic. And that can be another BHC or nurses or any person in the clinic that they can actually understand your notes. We're gonna really remove the traditional mental health notes, which are long, which they involve an intake. This is gonna be a completely different approach of how to write the notes. So stay tuned for next month because we're gonna be talking in detail about that. But again, going back to the importance of being brief when you report to the providers, but also when you write your notes. It's important to be assertive and curious. A lot of the times when there's new providers or new BHCs that they're starting in clinic, and I see this a lot with trainees, well, they're shy, they're learning, right? So when a provider comes to the room, the first thing they do, they start in the computer, start writing. Instead of giving the nonverbals as to turn to the provider and say, hey, how can I help you? Or even just, have eye contact. And that eye contact, sometimes it's the clue for the provider that, oh, I saw a patient that I want to talk to you about. So it's very important that nonverbals and be assertive with your body language, but also the verbal language. And curious about to tell me more about it. How can I help with this patient? And that's also the importance to be in the same huddles and the same physical space. Infuse yourself into clinical aspects of operations. This means that, like I mentioned early, we want you to be and mirror whatever the providers are doing. So if providers are involved, let's say in the interview of a new person that's going to join the clinic, you should be part of that interview as well. Or if the medical director is part of the leadership group on the clinic, then the behavioral director should be part of those meetings too. You want to understand really what's happening in the clinic. Sometimes it actually, like when we go and shadow a site, it starts even from the front desk. Like we go and sit down and observe what's going on when the patient arrives, how they're, welcome the patient in the front desk, what happens after. So just kind of understanding the flow of the clinic can also give you a lot of information where maybe you can improve that flow or where they're missing in thinking of you to be part of the team. You have probably, if you're starting the program or you identify a lot of things that are not helping the integration, at that point you have to prioritize and pick up your battles. Like what really you want to keep, you want to improve. So if there's a lot of things that you feel that they need to be changed, just by picking one, and start with that, can move you towards your main goal. And let work speak for yourself. Yesterday I was actually in presentation that David and Bridget, who are, they're you guys gonna see them in the pictures. Actually, it's Bridget who's in that picture there. We're saying that for providers, for medical providers, the most important thing that counts for them is not how much you tell them that you're gonna be helpful in their flow or with the patient, but to show that. So if you're able to allow one medical provider that he or she can see that you facilitate the flow, that you were able to complete the puzzle of a patient. Because remember, when they're seeing a patient, they're finding just one part of that patient's life. And your role is to kind of complete that other part that is missing. And a lot of the times when you're able to do that and you report that to the provider, there comes this aha moment for the provider that now they can understand why maybe the patient was not following with their treatment or they were having some difficulties as to the things that the doctor was prescribing. So when they're able to see that, they are going to be then your sponsors. They're actually going to let the clinic know and other people know in the clinic how for them it's important that you're part of that team. So really, with your actions, that's going to speak for yourself as to why you're valuing that part of the team. You're not there to just help the patients, but remember you're there to help the clinic, the providers, the flow. So in general, you're there to help everyone. We're going to talk about later with some screeners that can be helpful to kind of identify why is that the provider doesn't have a buy-in or why you feel you're not getting referrals and things like that. So this was just kind of like a little overview. Now let's go into more detail. In this presentation, for those who already have the PowerPoints, you're gonna realize that there's two links to a video. I'm just gonna show one today due to the time constraints. And this one is one that I'm not gonna show, but I'm gonna talk about it a little bit. So what is the huddling? The huddling, really what it means, it's that you're gonna review the chart of your provider and identify where you think you can be helpful for the provider. Then you will come and meet with the provider not more than 3 minutes to let them know, hey, I think your 9:30, it will be helpful if I see it because X or Y. Or I think, once the 12 arrives, if you're behind, I will be happy to talk to that patient because we haven't offered services yet. So just to give them some highlights. And then it's a reminder to the provider of how they can use you. In this process, you're teaching them on ways that they can use you that they don't even know. So that huddling in the morning, it's important. My personal style, I like to have time to do things. So for me, when I arrive to clinic, I arrive an hour earlier when my first patient arrived, particularly to have time to review which provider are going to be with me that morning, what patients they're going to see. And I'm able in my electronic medical record, which is Epic, to kind of point the patients that it will be easy for me or helpful to see. Then I go and report that to the provider really quick, and then I come back and start my day. And there are days in which I'm able to support those patients I mentioned in the morning. Others, maybe I'm not because I got busy, I got another warm handoff. But it's important just to train in those huddles to the provider how they can use you. Then with time, they're going to be the ones coming to you to tell you, hey, I have this patient in the morning that I want you to see. So that's important to get that into a habit, the huddle. I highly encourage you to click the video and watch it. They're just like 2-3 minutes, but that gives you a visual example of how you can huddle and talk to the providers about the patient. Now we have, and this is a very common issue that comes when we're doing our TAs support, when they say, well, I'm in the clinic, they know what I do, but for some reason, I don't get referrals from providers. And I'm there sitting and I'm not getting referrals. What's going on? A lot of the times it starts with even the introduction. What are the providers telling to the patients about you? So in this here, I want to actually show the video to highlight what are things that providers might think they're doing right, but it's actually doing the opposite. It's making patients actually run away from you instead of be part of their treatment. So I'm going to click play, and I will appreciate if I'm just seeing Naftali's and Julie's face, if you guys cannot, just to make sure the noise, the sound, it's coming across well. Awesome. Okay, can you guys hear me well? Okay, awesome. So let's talk about this video and any reactions that may have caused to you guys. Feel free to put it on the chat. The way that we get introduced is very important. That's actually the front door, right? If they do it right, the provider are actually opening the door for the patient to say, yes, I want to meet with the BHC. So the idea of being introduced as a team member, it's very important. Just by that, it's presenting or introducing, we having integrated services, right? We're a team. So that's very important instead of the counselor or the therapist. I do know, because I have seen it, that once you get introduced by counselor and therapist, right away it's like, but I'm not crazy. What you're thinking about? It's just my sugar levels that, they're really high. Why do you want me to talk to a counselor? So again, like Jeff was mentioning, the mind of the patient will go right away to another place. So very important, the words that they use in the introduction. That you're coming with an expertise that actually is going to help their condition. That also kind of makes them think, okay, I think I want to hear more about how to improve X or Y issue they're having. It's actually, and I know probably when you're just starting the program, it can be hard, but BHC should be involved in the care, of the patient as a routine, not just when they have problems, like medical problems or emotional problems, but just being part of the flow, just like they do high blood, they kind of take your pressure when you just start, the meeting with the provider, the nurse, welcome you, they take your blood pressure, they ask you about medications, we should be part of that role too. So ideally, that's what we want to be invited in the regular flow of when a patient is coming to being seen at the clinic. Important to mention that you're flexible with time. A lot of times they have been in the clinic for a while, they went to labs, they need to, go to their jobs or whatever. So the idea that it's not a long-term therapy of 1 hour, but it's like maybe 15 to 20 minutes and that you're gonna be helpful in that short period of time. And let the patient know that that is gonna, when you meet with them, it's gonna help the PCP understand the problem better, but also the patient understand better. And Naftali is putting here on the chart that targeted treatment. With I know we're gonna be also talking in other sessions in more depth, but that's super important to be able to identify what the patient needs now and what's the best way I can help the patient today. Thinking that maybe it's gonna be the only session that the patient is gonna be there. Because we do know that a lot of the times if we refer somebody outside, they hardly follow up that, or they don't come back again to see their mental health, provider or help. So as BHC, we need to have in mind to think about, if I'm not going to see this patient again, what I can do today to improve the patient's quality of life if they don't come anymore. And if you're able to do that little switch in that session, you can kind of pat yourself on the back because it was a successful session. Remember, I mentioned that it's important that we are seen together as the medical providers, and that starts with everything that the medical providers are doing, BHC should do. So you're gonna use the same exam rooms. You're gonna avoid actually to be in a different, room where they go and see the counselor, but instead you're gonna exactly do what they're doing. The same scheduled process. For some clinics, the provider cannot schedule patients. If that's the case, we recommend that as BHCs, it's the same. So exactly the same. The introduction as a team member, that again, it's part of the care they're receiving. And just like, when you come and see your doctor and going to take labs, it's part of your routine. Well, it's part of the routine also to see your BHC person. Be part of meetings, interview process, like I mentioned early, represent in the leadership at the leadership level. It's very important. And the way to do that, it's actually to start creating relationships with people in the clinic. Because, if you're just starting the program, they don't know that actually it's important that your voice it's at that table. So creating that relationship does help. I mentioned about the logistic of the building, and that's very important. I actually, we're just supporting a clinic right now in which they got us involved in their building project because they're kind of expanding the clinic. And that's super helpful because a lot of the times, the way the location and the building is set up, it actually avoids the integration, doesn't help when there's a lot of closed spaces. So you want it to be together with the providers in the same area, not in another floor, not in another building. There's a misconception that a site will have integrated services because there's mental health providers in the clinic. That is not integration. That's regular mental health services in which if the provider feels they need support, they'll send the patient to the second floor to make the appointment with Martha. And Martha never communicates with the provider. So that's not integrated care. Integrated care, it's being and doing the same thing providers are doing, being on the same floor, communicating with them, closing the loop about patients after you see the patient, being able to talk to the provider. That's integrated. Like I mentioned, sitting provider spots, do not sit in a BHC office apart. That's very important. I cannot tell you how many times when I'm in clinic sitting in the pots with the provider, just by listening to them talking with the MA about patient, it's a warm handout for me that they didn't know. And I just will turn and say, oh, I think I can help with this or that. So being part of that communication, it's important. Being in the same area with the providers also help you in regards to closing the loop. So the provider referred a patient to you, you went and saw the patient, came back, the provider is seeing other patients, but then the provider comes to document something to their spot or talk to the MA, and that's your opportunity to loop back on that patient that you just saw before. And again, remember, you have to be brief and direct in that report. You just want to inform them and not kind of stop them of what they're doing in their flow. Going back to also, that reminds me as to the importance to reflect exactly what the providers are doing in clinic, that it should be reflected for the BHC. Just, recently in the clinic that I work, the way that the patient arrived to the clinic, the MA will room the patient for the providers, but they were not doing that for BHCs, right? We had our director, or actually our chief behavioral health officer, who has a representation in the leadership, role, and she noticed that. She noticed that we were not, really reflecting that as the providers. So she brought that up, and there was a consensus in which now patients were going to be roomed for ourselves as well, for the BHCs. So the director of the MAs exposed that to the MAs, and of course there was, some pushback. Oh, we have so many things to do, we're going to get confused. So who's going to be with which BHC? So there was a lot of pushback in the beginning. They kind of report the difficulties that they were envisioning that they were going to happen to their director of MA, and that person reported to the chief of behavioral health. They together brainstorm ideas on how to help the MAs, get a better flow of the process, and we implemented that. The first month, it was chaotic. Some MAs were doing it, some MAs were not doing it. There was still a pushback, and our chief behavioral health officer reported that to us, saying, this is a change for them, but let's start reinforcing, giving positive reinforcement when it does happen, and guiding them. So instead of us continue with the idea of rooming our oral patients because the patient was there and nobody was doing it, and you had the urge to actually just room it yourself, we start just kind of guiding the MA. Hey, I think my patient is here. Do you mind rooming it? Oh, yeah. So, so we start kind of teaching them on that flow. Now it's been probably 3 months. It's running super smooth. Everybody got into the flow, and is running beautifully. And again, it's an example of how we were just reflecting that whatever it's happening in the clinic, in the flow for the providers, it happened for the BHC too. It doesn't go smoothly right away. You're gonna have some roadblocks there, but it's important to brainstorm and keep the communication in order to improve that. The scheduling process, I mentioned it as well. If the providers are able to schedule their patients, you should be able to do that. If they don't, it's important that you probably do the same. If they start at 8, you should start at 8. If they leave clinic, last patient is at 3, that should reflect also the schedule of the BHC. So always the same process. To facilitate that is not confusion, because again, you're part of a team. You're not a mental health provider who is in another place, okay? And this is a big one, particularly when you're implementing the program, how to change the culture. How are you gonna change the culture of the clinic? I just mentioned the example of the MAs, right? The culture was that they never room patients for us. So there was a need to change that culture and to plan and communicate and, keep reinforcing. So it was not easy, but it's important to create that change. How to do that? If we go back to the example I did, we have somebody, our head of the BHC, had a representation in the leadership group. So that was easy for her to bring that issue to the leadership of the clinic and be able to communicate with the head of the MAs, right? So it all started because we have representation in the leadership part. Usually, I do know that the head of our BHC program it's present wherever the medical director is going to be. I do know, for example, that we were hiring new providers, and the medical director was part of the interview, but also our director from BHC was part of that interview for medical directors, right? When it's the BHC, the other way around, if we hire a new BHC, we include a medical provider to be part of the interview process as well. So it's a mirror. You have to really think like mirroring everything. Whatever the Department of Medical is doing, the Department of Behavioral Health should be doing.
Martha, can I step in here real quick?
Yeah, go ahead.
Give you a little bit of a chance to breathe a little bit.
Yeah.
So just a note on that, it's very important because folks will ask this. So
And if you can speak louder.
oh, sorry about that. I hope I don't have the wrong microphone on here. So 1 second. Keep going. I'm going to take.
Okay, sounds good. And again, it's important to mirror that because those little things that you're not included, they start growing and then you start feeling completely apart. But if you start to be included and you push to be included, the more you're going to be part of what's going on with the clinic, with flow, and we be involved in everything.
I'm ready here.
Yep.
Can you hear me? Okay, great.
Perfect.
Is that the wrong mic? So a key point that people ask often is kind of how to represent this on the organizational chart. And so a key nuance here is that in the organizational chart of well-developed clinics, it'll look as if behavioral health is its own department. And in fact, functionally, what Martha's describing is its own department per se. But it's different than, say, like medical and dental, for example, where they're two very separate departments. The whole reason for the existence of the behavioral health service line is to support the primary care service line. So that's just a nuance you want to keep in mind, that even though on your org chart, yes, you're going to need a CMO and you're going to need a CBO, Chief Behavioral Health Officer. And they both have their staff underneath them and all of that. The main difference is that functionally, your CBO's job is to support the primary care service line, right? So it's not its own department. We do see clinics where they've developed a behavioral health department, but it develops so separate from the primary care department that the same problem that Martha's describing happens, where you have co-located services that don't really interface with one another. So just a key piece, nuance to thinking about your org chart.
Yeah, I'm glad you brought that up, Nev, because I think it's easier to get so disconnected. And that's when we have to mention that it starts with the relationships and always push to be back, kind of allow yourself to invite to be part of those meetings. I remember back in the days when we didn't have still the CBO yet, that position was not there yet. That person who was in that leadership role will just voluntarily say, can I join your provider meeting just to hear what's going on and kind of understand what was the flow? And even if that person was not invited, but just kind of having that mentality of, I want to really know and want to get into this and see what's happening. And then in those meetings, which the person was just hearing like a fly, that person started actually later providing some input that it was helpful. So then people were turning to say, oh, now we know who this person is representing, and it will be helpful. And like Naftali was saying, support the line of the providers. Okay. Now, it is important to identify medical leaders. So there's always going to be someone that really believes in the model, that it's seen the value of the model, and that can be actually your sponsor, can be someone that can help you sponsor the integration, how you help and be in the program. So it's important to start identifying those individuals in your site so you can pair with them and start working with them. And like we mentioned in the beginning, with your actions, they can see the benefit of it is working with you. And then they can actually also support you throughout the clinic in general, but also be the person that others providers will copy them. So this is contagious. If they see that one provider is using you a lot, the other provider is going to start using you. If they see or hear that the provider is saying, oh my God, I had a really hard day, I was so behind, and I'm so glad you went and see my patient, and you're in the pod and everybody's there and the other providers are listening to that, the next time the other provider is behind, they're gonna kind of allow you to be part of the flow. So it's very important to identify those leaders. And we have here actually a module. It's a 1-hour module that it will be helpful if you guys want to review it. The link is there. It's in our CFHL Learns and Share platforms which we have a lot of educational courses, but this one it's a good jewel that we have there. It's a really one, and that I think it will be important for you guys to watch, because remember that this is a pollination process. So you're helping the provider and educating the provider how beneficial it is for them to have you, but also they are teaching you how they're working and how their flow it is, and how important it is that you both work together. And one of the things, and I don't know if it comes in the other slides, and maybe I miss mentioning, is that if you're having difficulties getting buy-in from providers, one strategy that you can use, start shadowing your provider. Get to know what's happening in their sessions. Get to know how is their life, what type of patients they're seeing, how is their flow. Do they really have time to see all the concerns that the patient is bringing? Like, get to feel how it is the life of their provider. And in that place of shadowing, you can also support and tell the provider after, hey, remember you just saw a patient and you spent 15 minutes of that session talking about how sad this patient was because they just got divorced. And then you didn't have time of actually finish with all the medical questions you have. I can be helpful in those circumstances. I can definitely be helpful if you refer to me, and I can explore more, or I can complete that part of the puzzle that I was mentioning in the beginning. So shadowing your providers is helpful. And if they allow you later, they can shadow you, and that is also helpful. So they know what you're doing in the room with the patients. So now I'm gonna stop sharing here. You guys are not seeing anything? Okay. And I stopped sharing.
No, actually, we're still seeing the slides.
Oh, I know what I did. Wait a minute. I have to confess, I am not good with Teams, and I had to take an hour tutorial before this presentation to know how to put the video and the presentation to all of you guys today. So I feel really accomplished that I did it. So
You did great.
I actually took notes of my steps. You guys are gonna laugh. Anyway, I'm more a Zoom person. But I'm removing, sharing the screen because I wanna show you. So all this sounds great, right? Like how to get the buy-in, how to identify how providers need to introduce you, getting your, hearing, being part of the logistic of the clinic. That sounds great. But it's also not so easy for the providers to let you know what they're doing wrong, because sometimes they don't know what they don't know, right? They don't know how they can use you, or what are they thinking about you being in the clinic. Are you really, do they feel really that you're blocking them, their flow, or that it's hard to introduce you? Remember that this is something that probably they never had before. That was something that it didn't come in their training either, when they were training for being medical provider. So there's two screeners that the link is in your presentation. And I'm gonna start sharing again. Are you able to see my PDF? Great. So this is a screener that is helpful to give to providers in regard as to what can be the barriers for them to give you patients that same day. So the warm handoff, right? And this can give you a lot of information as to what are the things that maybe can be improved. Maybe it's as easy as the introduction, right? So for example, maybe they're not sure how to make that request. Do they feel shy of knocking at the door if you're seeing a patient or not? They forgot. they didn't have the time to include you. Maybe you were busy and they didn't know how to kind of get to you. They saw that your schedule was full. Maybe that notion that they don't know about the warm handoff, right? Couldn't find you. So where are you? Like, is there a communication of flags or colors to let everybody know where they can find you? I can tell you that in our clinic, our flag is red. So when I go into a room, we put the red flag out, but also in our computer station in the pod, we had a little whiteboard and we write the room we're going to be there. So instead of the provider walking through the halls and find the red flag, they'll come to try to find me to my computer place in the pod, and they know, oh, Martha is in 116. So they go to 116, knock at me and say, hey, I have a patient that I would like you to see. Or they will let the MA to kind of let us know that there's a patient that they want us to see. So it's so simple. It's so simple to get just a whiteboard in your station or a sticky note, but you will not know that that was really affecting the referrals you were having. And these type of screeners does help a lot to identify those little tweaks that you can start doing. Our patients like the video, are they refusing to see you and what is the reason? So see how in the video, Jeff start asking, well, tell me how you're introducing me. And by the first sentence that the provider gave, he can identify, oh, I've been introduced like a regular mental health provider, like a regular traditional service, right? And that was a moment of education to the provider. And then again, that will help and affect the numbers of referrals that you will start getting. So it's a one-page questionnaire that they can do, and that's for the same day referrals. So these can be helpful if, again, you feel you're not getting warm handoffs right, like you don't getting at all. And you can see your providers running and being busy, but you're not getting referrals. And we have there's another screener, which is just using you, just in general, right? And they will, again, the provider will fill that out. The patient is already seeing a therapist? Are they running out of time? Patient refused a referral. Again, this is going to give you information as to what's happening when the provider is introducing you. Not sure how to refer to BHC. Yeah, a lot of the times it's awkward because they are not used to have you part of their team and they don't know how to introduce you. But bringing these conversations are very important because, again, sometimes are the simple things that are affecting the integration in your program. How to speak patients in the primary language. This is so important. So if we translate a behavioral health consultant in Spanish, is the most awkward word you can hear. So the patient will have like a huge question mark, like, who's gonna come? Like, I don't get it. Because if it's translated literally how it is, it doesn't mean a lot in Spanish language. I know also for Arabic language, and I know also for Hmong language. Those are the three that I do know that if they translated exactly the same, it doesn't make sense. So for me, when I go and see Spanish-speaking patients, and I also work with Spanish-speaking providers, I'll invite them to tell them, describe what I do, instead of putting me a label. So instead of saying a behavioral health consultant, it's someone that works with me who has specified in sleep issues. So it's kind of tell them more what I do, just like the video that Jeff described. That makes more sense to them than just the word that automatically, when they don't understand it, they're afraid, like, no, I don't want to meet with that person. It's like eating a new food. No, I don't understand what it is. I'm not going to eat it, right? So it's very important to identify when we're working with Spanish-speaking patients or any other language. Maybe they're doing well. They're responding well to medication. They don't need you. Yeah, that can happen, but a lot of the times it's not just related to medication. You can support the patient in other ways. If they need, specialty psychiatry care, and depending if in your clinic you have consulting psychiatry or not. And we do know that there are patients that might not be appropriate to have care in primary care. That's okay. But when the majority of the patients are referred out, there's something you have to look at is what's happening in that referral process. Or even in the behavioral health consultant way of seeing the patient. I feel lately, particularly with the pandemic, mental health issues kind of got expanded in increasing level, that for a BHC, it was overwhelmed to see a patient with so many issues and very stressed and a lot of mental health difficulties. And automatically, we were jumping into trying to solve the life of the patient. But really, we're seeing the patient in primary care. We really need to think about how I can help this patient, again, function better. Am I not going to be able to fix the loss that they have in the last year with COVID, the trauma of losing their job? I might not going to be able to fix that systemic issue, but I can help them see how they're thinking about this and how they can function better with what they have in their context, in what they're living in that moment. And that's the goal. Now, it needed to be a shift from my end because I have to confess that in the beginning, I was jumping to try to solve everything. And what happened is that I realized I didn't have capacity to give follow-ups to patients in a week or 2 weeks or a month. My agenda was full. So I knew I was injecting some of my own anxiety to bring the same patients back right away, instead of being smart, like Natalie was saying in the beginning, with that titration of care, and when was necessarily to bring them back and what really to help them. I also felt, because I was overwhelmed at the end of the day with things that I thought were simple, but I was just getting overwhelmed with everything that was presenting in the room with the patient. So it's important to kind of take a pause and a step back if we find ourselves being overwhelmed or we cannot, create some follow-up with patients. What are we really doing in the room with the patient?
Martha, just a quick note here, because there's a thread that cuts through a bunch of these items on this screener. And that is when your providers are doing too much of the triage process. So if you think about like, patient needs specialty psych care, right? Or if you scroll up a little bit, Martha, to item number 1, patient's already seeing a therapist. There's a bunch of these items that relate to the idea that the provider is really doing too much of the triage process to determine. And we want to actually offload that work from the provider, in large part because our ears as mental health professionals are more attuned to some of the dynamics of whether a patient will engage with care effectively, what level of care they might benefit from, what kind of care they might actually need, even down to specificity of their actual diagnosis. And so one way we would try to solve this is by educating the provider team and saying, hey, let us bring us in early to help you make those determinations. And in fact, oftentimes in some of those cases, you just have to coach your providers to get out of the room quicker so that they identify an issue and then allow the BHC to come and do the triaging and then report back to you as the provider around, hey, I think X, Y, and Z is probably the best way to go with this person. And that teaches the providers how to co-work with their behavioral health staff and get out of the habit, because a lot of providers are in the habit of doing everything for their patients and making all the determinations, which in the end kind of burns them out. And then oftentimes leads to, unfortunately, a lot of inappropriate referrals out to specialty mental health. It's happened many times for both Martha and myself, where a provider is already thinking that they might need to refer this person out either for a psychiatry appointment or therapy appointment or some other type of care, even just to the emergency department. And then they'll invite us in, and then we come out with a very different picture. And we say, actually, I'm not sure that sending this person to the emergency department is either helpful or necessary today. Yep. But we worked on this as part of the plan. Does that sound okay with you? And a lot of times the provider's eyes will open and be like, oh, yeah, that's great. That's great. I'm so glad that you were invited. And then that becomes one of those aha moments for the provider. Yep, this is what my teammate does. I can rely on them. I don't have to be super provider and do it all.
Great. So with this, we end the presentation of today, but I purposely left time because I want to know, Neftali, I don't know if there was question on the chat or if people are, what are your reactions to these presentations?
Yeah, no, we didn't have any particular questions, but I was wondering if people could let us know what the buy-in currently is for this kind of approach. And again, I'm not just talking about buy-in. Sometimes people talk about, yeah, our providers are really bought into the idea of having mental health support for their patients. But this is really talking more specifically about buy-in for this kind of teamwork. Right, that's the buy-in we're talking about, because every provider will say, oh yeah, I want my patients to have mental health support. This is about buy-in for this kind of teamwork that does include very specific workflows, ideas of how we work together and take responsibility, co-share responsibility, sharing exam rooms, sharing flow, scrubbing and huddling, all the stuff that Martha talked about. Is more nitty gritty. So if you could either put in the chat or unmute yourself and let us know, like, what's buy-in like? What do you think buy-in is like at your clinic for this kind of approach? We'd love to hear where you all are at with that.
And we are aware that some of your sites are just starting or thinking, not even just doing it. Others of you guys are more advanced. So it doesn't matter where you are in your stage of integration. Please share how you think this will look like at your site, or it is already.
This is Ann from Primary Care Associates. Here I can on video as well. We are just in beginning stages of the whole idea of this. I have one physician champion already who's super motivated, but we haven't even talked with our board about this yet. But as far as buy-in, I'm sure our providers would appreciate this type of approach, but we are busting at the seams with no more space as it is. So just wondering how different organizations do that, like to share the exam rooms and being right where the providers are sounds excellent, but we might, in our busyness of schedules, might not be able to support that. So what are some options?
Yeah, I was just telling this to somebody yesterday, and Martha can remember too. I mean, one of my first spaces was like a closet. I worked out of it. And it wasn't even a closet. It was an indentation in a wall in the hallway. And so, we always recommend start with what you have. And so the ideal is working in and out of exam rooms. I've worked in 2 exam room situations. In other words, when providers only have 2 exam rooms assigned to them and with no overflow rooms, right? And so there's ways to make that happen. What you have to do is make sure that the mental health professional, the behavioral health consultant, understands how to work the flow together with the MAs and the providers so that it's efficient and you make sure you're not slowing down flow. It helps if you have at least an overflow room that you could potentially move patients to, or the provider can use and move their next patient to. So that certainly helps. But honestly, to be perfectly honest, even in the worst room space situations, the providers and their teams make it work because you learn how to leverage the extra time you save. So you're bringing in someone. So instead of spending a full 20 minutes maybe with a patient, a provider learns, oh, okay, most of this visit is actually mental health related. I'm going to be in there 7 minutes, pull in the BHC, and that's going to save me, a good 15 minutes or so, right? And so the providers then learn to leverage their teammates to make sure that they're just focusing on the parts that are essential for them to get accomplished in that visit, handing off as quickly as they can, or in some situations, actually asking the behavioral health person to start the visit while they're with another patient, because I know, more than 50% of this visit is medication refill for antidepressant medication and the patient getting their behavioral intervention. And I'm going to be there to just kind of tack on, get a check-in on their diabetes and do their refill, And so when the team understands that, space becomes a lot less of a constraining factor.
Thank you. It's very helpful.
Yep. Any other thoughts in our last couple of minutes? Well, my hope is that as you've listened to this, you do understand that difference between general buy-in, because we've never actually met a clinic that said, oh no, we don't have buy-in from our providers or our organization around this. But it's actually the specific buy-in, all those nuances that Martha talked about that are the rub sometimes. And that question that was just raised is one of those. There's a lot of protectionism around space because space is at a premium in primary care, right? And so you have to work through those issues with your primary care provider so that they don't get anxious about, oh my goodness, this is going to slow me down, when it's the opposite is true. Like, we're actually going to speed you up. We're going to help you get out on time. That's part of our job as your teammates. And so working through those little nuances of even just like communication, the flag systems, the communication systems, how you huddle, all those pieces are key pieces to making this flow work. And that's what buy-in actually means.
I want to say thanks, you guys. It was a terrific presentation. The chat was amazing also. So I want to let everybody know I can download the chat. And when I send out the link to the Survey Monkey, if you all promise to fill it out, I'll give you the chat too. No, I'm just kidding. You'll get the chat also. But if you would fill out the Survey Monkey, I'd really appreciate it. I'm also will send out the slides a week ahead of time again. And again, if you all want to do some one-to-one sessions with Neftali and Martha, you can get in touch with them either through me or directly through them. You have the contact information. They have been doing one-to-one sessions with people who are thrilled about how that's going. So take advantage of that to just ask your questions, work through things, learn more, and have a great day. You're all pretty fabulous, and I know you're working hard out there. Thank you all so much.
Bye, everybody.
Bye, everyone.
I will get that PDF, Ann, for sure.